Hello, everybody. Thank you for joining our learning collaborative. We're just allowing a few more seconds for other participants to join, and we will get started soon. And this is just a kind reminder to please mute your line if your line is unmuted. Okay, let's get started. So thank you everybody for joining us today. Today we will get started with our learning collaborative on enhancing the use of clinical preventive services for older adults. This session is also brought to you by the National Center for Health and Public Housing, and this is the first session of our four sessions learning collaborative. So about the National Center for Health and Public Housing, the mission of NCHPH is to strengthen the capacity of federally funded public housing primary care, health centers, and other health center grantees by providing training and technical assistance. The content of this learning collaborative is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. And then this is just a brief introduction about the speakers for today. So with us today, we have Dr. Kevin Lombardi, who is the Director of Research at the National Center for Health and Public Housing. Dr. Lombardi. And then myself, I am Filipina Sandoval. I am a Training and Technical Assistance Manager here at NCHPH, and I will be co-moderating today's session along with Dr. Lombardi. All right. And before we continue, I'd just like to remind everybody that your line is muted upon entry. If by any chance your line seems to be unmuted, please make sure you mute the line just so that we don't have a lot of interruptions throughout the engagements that we have with our participants. Since this is a learning collaborative, the engagements that we will be doing are a little bit different than from a regular webinar. During a learning collaborative session, we usually encourage all participants to provide their feedback. It could be verbally or in the chat. You could also raise your hand. And then your line will also be unmuted. And do expect that throughout the session, we will be asking some questions to all of the participants about a few case studies. We would also like to know more about what you're doing at your current organization. So feel free to chime in. And also just a reminder that there is no right or wrong answer for whenever we do these case studies, but we're all here to learn. So this meeting is also being recorded. The slides and the recording will be sent to you all via email after today's session. So here we have just a brief summary of the learning objectives for the learning collaborative as a whole. So do expect to learn on how to identify key health-related social needs that impact access to clinical preventive services. We will also be analyzing the barriers faced by older adults in utilizing preventive care and propose actionable solutions. Throughout this learning collaborative, we will also explore evidence-based strategies for improving preventive health services in public housing communities. And we will also be discussing the role of healthcare providers, community organizations, and public health programs in enhancing access to preventive services. And now, without further ado, I will pass it on to Dr. Kevin Lombardi to get started with the session.
Hi, everyone. I'm so excited to see everyone here today, and I can promise you that this learning collaborative is going to be a blast. This is a subject that means a lot to me. My name is Dr. Kevin Lombardi. I'm a physician and epidemiologist and the director of research at NAM Health and NCHPH. I'm in my office now. That's my medical degree. That's a Sicilian flag, and those are my mandolins. And those are the things that keep me happy. I'm a single father of one full-time, And my mom got me this sweatshirt. It's music and a heartbeat, heart rhythm. So that's the kind of stuff that moms get you when you become a doctor. So that's me. My work is focused on residents of public housing and enhancing the medical care they receive through TTA and public health interventions. So my history is from before medical school, I worked as a street paramedic in the Boston area. I was one of the responders at the Boston bombing in 2014, and at the crux of the beginning of the opioid crisis, was in a community that was quite affected by it. In medical school, I went to the George Washington University and performed my residency in internal medicine. I performed my MPH after residency and now function as a physician scientist epidemiologist. I will be speaking about this topic in very clinical terms. This will be an extremely informal place. That's why I got the sweatshirt. And we'll be talking about it in an informal way. But we will be going to great clinical detail with these patients. Our teaching and our learning and our discussions will be case-based, because that is the best way to learn medicine. That is the best way to break patients down. And through doing that, we'll be able to understand the whole infrastructure, from the clinic to the home, from in everything that is in between, pre-hospital, hospital. We need to understand the ecosystem in which these patients live and how their chronic disease states, their levels of ability or disability impact their ability to maintain their health and get good health outcomes. And we are going to do everything we can to understand how those individual elements exist and how they sort of intervene in the tapestry that is our patients' lives. So very excited for this. Excuse me, it is allergy season. Next slide, please, Fide. Oh, Fide, who are you and why are you here today?
Hi, sorry, and thank you. Yeah, my name is Fide Pineda, just as I briefly mentioned earlier, but aside from being a TTA manager here at NCHPH, I obtained my undergraduate degree in community and global health at George Mason University here in Fairfax, Virginia. I'm also currently pursuing my MPH in epidemiology, so fingers crossed I'll be all done this summer. So I am looking forward to expanding my career and, of course, doing a little bit more research for the special vulnerable populations here in the US. And then I am
You got to
also,
clap, Fide. You got to clap.
thank you. Thank you, Crystal. And then I am also a community health education specialist. So putting all of that together has really helped me with providing community health centers the TTA that they need and helping in target your needs more specifically, also based on what you provide to us. So all the feedback that you give us, even during like the post-evaluation surveys, anything, even during like your registration, it really helps us organize and narrow down how we can better provide TTA to you all. But yeah, this is
Oh,
just
yeah, after this session, we will look at that feedback and we will integrate it into that next session. Fide makes sure we do that. She yells if you don't. She yells, so we have to. So here's how we're going to do introductions. We are going to be pulling you guys into the conversation with a raise hand or throw a comment in the box system. The way this works is we do this because we're trying to make this as Socratic as we can. So I will pull you all into the conversation as we go through the case. And the way I'll pull you in is if I see your hand, you're the next one. I will grab you and pull you into the conversation. And at that point, introduce yourself, do your introduction. If you want to put something into the comments, I will ask you, or Fide will ask you if you want to join. How did I do, Fide? Did I describe it right?
yes, that's correct.
Okay, cool.
The only thing is
Okay.
like sometimes with the learning collaborative, you may not be able to raise your hand. Sometimes you can, but I don't know. Sometimes I'm able to see. But either way, I can always just unmute your line. So.
Okay. Okay, sounds good. Let's get into the content. Next slide, please. And this is from a day that I really enjoyed. Are we at the case?
Yes.
Okay. So here we are, folks. Fide, am I coming in okay? I'm getting a tiny bit of a lag.
Yeah, so right now we're in the case slide. Do you want me to move one slide back?
We're fine. We're fine. So hey, here's how I teach. It's based on case studies. For medical providers, this is our bread and butter. And why case studies? Why are they important and why are we focusing on them? One, the way I was taught was through the Socratic method. I saw patients, I learned about body systems, I practiced it in clerkships, and my attendings asked me a lot of questions. They asked me about what the patient's information meant, what interventions I would do, questions upon questions upon questions. We will be doing a low stress version of that, where we will be going through the details of the patient's history, their medical history, their diagnoses, their medications, and we will be digesting that in the fullest through the case study and via the Socratic method. So this will be, in a way, a interpretive theater exercise. It is important to me that all of you leave this learning collaborative understanding these patients and what their daily lives are in a myriad of ways. And the clinical is at the forefront for me. Through that, we'll be able to discuss the promising practices, the interventions, and where the rubber hits the road, talk about social interventions that work and the ones that don't. So, Mrs. Tiller, 73-year-old woman and resident of public housing, my window, who presents in your clinic for a 6-month wellness visit. The patient has a past medical history of hypertension, type 2 diabetes, last one, A1C was 6.6, osteoporosis, hysterectomy in 2009, breast cancer, breast cancer in 2006, status post mastectomy, vitamin D deficiency, anemia, a microcytic anemia, generalized anxiety disorder. Okay. The patient takes a total of 20 medications for these conditions. She has them listed on a piece of paper on her person that she says her daughter wrote for her. Fide, let's start with you. What's coming to mind as I describe this patient?
Um, well, one, I guess, is the age. In a lot of the medical history that this patient has, and it really stands out to me also the medications, has a total of 20 medications that this patient is also taking for all of the conditions that she has. So it makes me question about how this patient is managing to be able to keep up with the treatment. Hi, Dr. Lombardi. Can you hear me?
I am going to jump on the phone because my internet is having an issue.
Okay.
One moment.
All right. Let's provide Dr. Lombardi a few minutes here. Our apologies, but as you know, sometimes with technology we can have a little bit of technical difficulties.
Hey, Fide.
Hi,
I
Dr.
think
Leon. How are you?
you brought up a really good topic here, and the very first thing that we see in patients and senior patients is the fact that they take a lot of medications. 20 medication is basically very difficult for a 73-year-old woman to handle, and making sure that the medication is taken at the right time. That's going to be a really good conversation about polypharmacy. I guess that's what Dr. Lombardi has in mind, in addition to other topics here. But I think that you mentioned something that it also grabbed my attention.
Mm. Thank you for that, Dr. Leon. And I'll ask, am I coming in well now?
Yes, much better.
Okay. Well, you guys went on some really important things there. And I want to ask the audience, could we please get hands? What is popping out to you when you see this patient? And I'll ask you to put something into the chat or raise your hand and tell us.
Hi,
Hi.
Tirana. Did I say your name right?
No, it's
All right,
Tarina. It's
Serena.
fine.
Okay.
The A throws you off. Hello, everyone. What I wanted to say, what stuck out to me is that she has listed them on a piece of paper on her person that says that her daughter wrote it for her. So clearly there's not someone with her consistently. And so she has to remember that and even remember to tell someone else that. And so when you relay information, it can get lost. So just making sure that everyone understands, like, is she supposed to take all these medications at one time? When is she taking them? Is she eating adequately, taking these medications? Because that can also cause a delay in the care too as well.
100%. These patients are very complicated. And when you have 10 chronic diseases and 20 medications, it takes an engineering degree to be able to coordinate all of that. So I will congratulate you for where your attention is going. That is 100% a priority. And, uh, this is really typical. Oh, I'll ask you, please, uh, tell us who you serve and how you serve them.
Okay, yes. I serve the residents of Cincinnati, Ohio. That's where I'm from. We have a program called the Family Self-Sufficiency. And so it's a volunteer program that residents can join no matter what their age is. And over 5 years, they can build an escrow to help with home ownership, buying their first car, furthering their education. So sometimes it looks different. And so I see all different type of residents that I serve.
I've heard of your program. I'm
Mhm.
pretty sure I ran into a colleague of yours at a conference
I'm pretty
presenting on
sure.
it. I'm pretty sure I did. This. Congratulations on such fabulous work.
Great.
We're
Thank
so
you.
so glad to have you. Um, and most certainly, the medications are a primary clinical concern. And as our colleague has shown us, it is going to be a social services concern as well. And we are going to have to look very closely at this patient's social collateral to understand how we can ensure that her medication is easy to take and she's taking it consistently. Fide, I'll ask you, please. Um, yeah, next slide, please, if you don't mind. I'm sorry. Do we have other hands? Because there is certainly more here.
Right now, I don't see anybody with their hands
And
raised.
I'll pull my scalpel out. So this is a resident of public housing, and I'm going to want to know when you practice around where there are residents of public housing, and you know the populations well, you're going to know which buildings are more likely or not likely to be safe places for an older adult to be. For public housing and for the HUD assisted, it is astounding how difficult it is to navigate their homes. They are not as disability accessible as you would think. And if we are considering people who are frail, older, who are at high risk of hip fracture, and let me tell you, a hip fracture for a 73-year-old woman is a life changing. life-changing issue. If she has to navigate stairs, if there are consistent broken elevators and so forth, these are things, if there is if these residents are in your patient population, know about these things. And the way to know about these things is through a good relationship with your housing organization, resident organizations, and so forth. It will give you public health collateral that will be very thankful for. It will help you to understand the various challenges that, in particular, patients like Ms. Tiller might experience. But I may be spoiling things a bit. When I see this medical history, there are some priorities that come to mind. And I encourage you, a lot of you guys are looking at this stuff all the time. Take a look at it and look at the tapestry. Look at it as a piece of art. All of these medical items, which this is a common patient that's going to walk in the door. This tells a story. This is someone who has a hysterectomy and breast cancer, double mastectomy. I'm thinking of hereditary BRCA conditions. I'm thinking of hereditary GNU conditions, vitamin D deficiency and anemia. Microcytic anemia is typically either a couple of things. It's iron deficiency most of the time, or it's an inherited condition like thalassemia. Now, this is a condition that is common in certain groups of people, but it's not terribly common. And you can expect with this patient, an older adult, and already has a vitamin D deficiency. And I'm really concerned about her diet, and I'm concerned about iron deficiency anemia. That will precipitate things like weakness, risks of falls increase with that. These are the things that we should be thinking about when we see these patients: is how can I make their lives safer, both through medical interventions, behavioral, and social. But these are the things that are coming to my mind. I see osteoporosis too, and that gets me very nervous because we have a patient with diabetes, with a vitamin D deficiency, microcytic anemia, possibly severe, who's walking around. And that says risk of fall, that says risk of hip break, and that is a huge red flag to me. And these things that can be hard to see if you don't look at the medical history like this. I really encourage you to do that and take it apart like it's a narrative, because that's what it is. Next slide, please. So we have some vitals here. Okay, Mrs. Tiller undergoes a standard intake. That includes vitals checked and a social needs screen, like the prepare. Here are her results, and we have the previous results from 2024. So oftentimes these patients are coming every 6 months for their Medicaid wellness visit. They need to. So you're seeing them regularly, which is great because you can look at the vitals from, going back a year and see is this normal or not. It provides an amazing baseline. Use your medical records to your advantage. They give so much context. And they can be the difference between a prescription that was necessary and one that was not, and between catching something and missing it. So standard intake, we have vital. Blood pressure, 145/72. Heart rate is 72. Respirations, 14. We have so this is a patient who has hypertension. She is hypertensive. It's not saying urgency or emergency. I wouldn't think that unless there was a systolic of 180 or 200. But this is telling me it is not optimized. This needs to be optimized. Okay. Well, sometimes people get nervous when they're in the doctor's office. So you got to look at the past results, get a couple of them. Heart rate, it's within normal range. Respiration's also not really a concern. 136/68. Okay, well, last time she was a little lower, but still higher than the 130 baseline that we want to see, which is one of the criteria for hypertension diagnosis. And heart rate and respiration is about the same. This is making me think more about that hypertension. This might not seem a lot, but an extra 10 systolic in your blood all day when you have diabetes and you have multiple chronic conditions raises your risk of, falling because of you have falling because you stand up too quickly, just syncope, vasovagal syncope, and it increases your risk of cardiovascular complications more than you would expect. Be sensitive to small changes in your patient's blood pressure, especially when you have reliable records. So, next slide, please. We have an SPOH screener. It is part of the standard intake. Fide, would you please read this social needs screen for our colleagues?
So for this one, the patient stated that in the past 2 months, the patient has been skipping meals or has been eating smaller meals. Is not experiencing homelessness. Also, the patient is not having trouble paying for her bills. She's having trouble finding or paying for a ride. So there is some transportation limitations going on. And the patient also does not need daycare for any children. And then in this page, she does list that she does feel unsafe in their daily life.
Okay. So these things go into the medical record, folks, and they are taken seriously. What incredible context a social needs screen gives the provider. These questions are hard to get to and take a long time. It takes a long time to get through this information through a clinical exam, through an interview-based clinical exam, longer than we have. We have 4 or 5 chronic medical issues. The social determinants of health or social needs screen takes that intensive interview that you would need to do, and it allows it to be done in a way that can be entered into the medical record system and is standardized. It's comparable. It's an incredibly powerful tool. Now, Fide, you read it right. I'm going to ask our audience, raise hands or put it in the chat. What is coming to mind for you? Do you have any questions? What are your questions? Excuse me.
Or have you, I guess another question maybe that I would have for the audience is, have you experienced or have you had any experiences with a patient similar to this one that may have the same or similar social needs?
Fide just wants to hear a different voice than mine, and please help her.
Are we muted?
Okay, yeah, we can hear you perfectly.
Okay. I would want to know, I do social determinants of health here. I would want to know why she doesn't feel safe and why all these things have been happening, why she's eating less, has somebody taken her money? I mean, where are her supports? What are her supports?
I love the patient safety focus that is reflected in your answer. But I'll ask before I answer your comment with mine. Could you please tell us who you are, who you serve, and how you serve them, please?
Becky Taranjo. I work at Mercer County Behavioral Health Commission as a Housing and Social Determinants of Health Coordinator.
Oh, lovely, lovely. Excuse me. Go ahead.
That would be my first question: is why she feels unsafe.
Yeah, no, 100%. And it's funny how much a checked box can elicit a response from a provider. This one here that says, "Are you unsafe?" could mean a myriad of different things. And when I consider an older adult, I like to consider the following. One, I am a mandated reporter. You are a mandated reporter. All of us, if we are seeing these patients or serving them, we are mandated reporters. And if we are suspecting elder abuse, we have certain professional responsibilities that are very important. There are also consequences to it if we do not fulfill them. So that is, professionally and ethically speaking, something that is going to grab your attention first. And I'll say that unsafe can mean different things to different people. And unsafe can also mean unsafe environment. It can mean partner abuse. It can mean fear of the outside. It can be psychiatric or behavioral conditions. It deserves your time and your attention. And thank you for that. I'll ask Fide, are there any other hands or colleagues that would like to join us?
I don't see any other hands raised, but you're also more than welcome to chime in and let us know what else also stands out about the social needs for this patient.
Okay, so I think there's a question next, Vita. Let's go to that. And I'm gonna throw this at you first. What I'll say is, let's look at the question. Our assessment of the social needs screen. Do any issues require your immediate concern? We've discussed this, but does this patient meet criteria for social services? Fide, what do you think?
Absolutely. I think one of the first things, just as we were discussing earlier, like for example, the issue with having the meals or skipping meals, I would like to know like what could be, affecting this patient, and then how could she be referred to maybe like a place where she can have free meals or
Yeah.
in their community.
Nutrition programs for older adults are a very important resource here. Are you focusing in on something?
No.
Oh, excuse me.
Yeah.
I 100% agree. We were talking about this earlier today, and I mentioned an archetype of person that I have spent many months of my life with, and the term I used was tea and toast. The tea and toast person. Do you remember that?
Yes. Yeah.
Can you tell me anything you remember about the tea and toast person?
Oh no, can you repeat it again? I'm sorry.
The tea and toast person, the patient, like the tea and toast lady.
Um,
What
at
does she
this
only eat? What does she only eat and drink? The tea and toast lady.
Oh yes, then of course that would just make their health condition even worse if they're not even having proper nutrition that they need.
So consider this, right? The tea and toast lady. This is very common. She comes in and she has a English muffin in the morning. She drinks her tea and she doesn't eat for the rest of the day. And this is very common. There are many reasons why people become this archetype of person. But I saw the tea and toast person 4 or 5 times a night for residency for 3 years. They come in because nutrition is a major, consistent, and persistent issue with older adults. As we age, our epithelium's ability to absorb nutrition and rejuvenate itself is reduced. As we age, our ability to distribute, absorb, and metabolize our food is reduced. And as we age, there are a number of social and environmental factors that make access to nutrition difficult. All of those things conspire to create patients that are challenged by multiple deficiencies in nutrition. Iron deficiency is almost universal in some communities in this demographic, almost universal. And that is my personal clinical opinion. When type 2 diabetes, and so you also have vitamin D deficiency and iron. Well, I'm thinking about this patient's ability to manage these chronic disease just on a corporeal level because they're not getting the appropriate minerals and vitamins for their immune system to function. This is going to make this patient also at risk for a number of life-changing and threatening conditions. Fide, remember, brought this up a couple of times about hip fractures in this population. Are they at higher risk of hip fractures?
Yes, absolutely. Yeah.
Why would you think that an individual like this is at a higher risk of a hip fracture?
Well, I think without going far with the example of this patient, right, from Miss Tiller, she also had osteoporosis based on the reading that we discussed earlier. So people or patients that have osteoporosis are just already in higher risk of hip fractures.
I
And it
need to
takes
stop you there. I need to stop you there because you found it. You found it. This is such an, excuse me, but this is such an important issue that we need to take a second on it. Osteoporosis leads to a thinning of the bone medulla. It leads to a thinning of the outside of the bone. Every part of the bone becomes, when you look at the x-rays, you can see the structural integrity of the bone being reduced, the lamina smaller. It is shocking how different a healthy limb or a healthy hip and a healthy pelvis looks compared to one that has had long-term osteoporosis. It is astounding. This is a nutritionally driven condition that also has significant family history and other components to it. But trust and believe, nutrition is a major driver of this condition. And if you fall and your bone is denatured, and it is less structurally thick, if it's 30% reduced, it's a lot easier for that to break. The bone is actually more brittle as well because it loses more collagen. So it doesn't bend as much. So it hits and it breaks. And when these individuals get those hip breaks, they have 6 weeks at least of recovery. They're often in the hospital for the operation, admitted for 1 or 2 days, and then they'll go for a rehab for 2 to 6 weeks. And their recovery is incredibly challenging. They need to relearn to walk on their limbs. There is incredible pain. And also, if someone's already having an issue with nutrition, and now they need to regrow bone and they need to regrow muscle, every 2 days in the hospital takes about 6 days to recover from, just for anyone. Uh, this often leads to something called the precipitous decline. And the precipitous decline is when a patient that is an older adult has an injury, a life-changing event like the death of a spouse or loved one, and experiences a rapid, I mean, 6 months to 2 years decrease in their overall health, and this ends with the patient passing. Uh, if you want to do good prevention for this group, you need to keep the precipitous decline in mind and keep in mind what does it for these patients. Because for many of them, when they have osteoporosis and a disability, the world is a minefield for them. They are walking around, and if just a car hits them, they could have a life-changing event that ends up putting them in a hospital bed. It creates fear in patients, it creates trepidation, and there are a myriad of ways that you can intervene to help patients. One, the patient needs to be eating well. They need to get meals sent to them. They need things, they need to be taught to cook if they can. Anything at your program's disposal needs to support this patient's nutrition. Now, there's a couple of ways to get vitamins, Fide. You can either get them through a pill or get them through your food. What does the data tell us? What is a more efficient way for your body to get and absorb those minerals? Is it your food or your medication?
for food.
Big time. It's a big difference, actually, folks. And there's all this fiber there that is so important for actually keeping things moving and maintaining good gastric and intestinal motility. Giving your patient the gift of a healthy diet is life-changing. In particular with these patients with multiple chronic diseases that are, when you see them, being exacerbated by a nutritional issue. If you address the underlying nutritional issue, you will it is hard to state how much you can potentially help this patient. Also, keep in mind, many health centers have things like the garden programs. One of our colleague organizations in Chicago has a new garden center that does cooking classes for residents of public housing. What a good idea. These are popular classes because they are community driven. And we also have a epidemic of loneliness in our older adult populations. And one of the best ways to prevent issues, to support their overall health, and in order for me to tell you pathologically, it would take hours because there are just so many ways that bringing food and community together through your programs will impact your patients positively. Please do it. And I'll ask, Fide, do we have any hands for someone who may want to add to that?
Yeah, no, we did receive some feedback from Tarina. She also mentioned also using her healthcare benefits. They may have transportation services and possibly can provide her home health aid.
May we ask our colleague to join us?
Yes, so I said that because a lot of our our residents are receiving Medicaid and they have a lot of great resources. For example, the transportation services where they could take them back and forth to the doctors, but they also will take them to the grocery store and other type of special appointments that they might need to get to. And if you looking more into it, it might be more than we know. They're seeming to wanting to meet people where they're at, so they're providing them a lot of different opportunities to make sure they have what they need. And then also, I'm not sure how it technically works, but I know that with their Medicaid plans too as well, they could have a home health care provider or maybe a CNA, just someone that's there checking them at least 8 hours through the day, or if they might need them more at night, maybe they might be falling out the bed and things of that nature. But that also takes a lot of support from the family to be able to advocate for them, because if you're not knowing necessarily what you deserve, then it's hard for you to advocate for that.
I love that. And I want to thank you for your comment. And I have a question for you in a moment, but I want to reflect on something that I think is so important. As a physician, I rely on the work of behavioral health and patient advocate professionals, CHWs, extensively. And that is because what you have just described, I do not see. It exists in my world through a medical record, and your ability to articulate these things and to address those patient needs, I find that very encouraging, and I enjoy and relish those conversations. And I'll tell you why. Because when you're talking about that stuff, I'm thinking in an intervention way. And I know if I'm trying to help this patient by giving them a bunch of pills for nutrition issues, and you're linking them to something like that, and you're also dealing with all these other issues, I'm thinking, wow, this is a ton of different support that I can't otherwise give my patient that is being executed on the ground now. It is a recipe for success. And I'd encourage you to have this conversation with physician colleagues when available and as much as possible, because we need and relish that information. Thank you for that. I'll follow up with a question that is, when you have observed these people, these patients, clients, whatever terminology is appropriate, I'm sorry, what have you noticed when you see someone that received this? What are the impacts on that individual on a personal level, medical level? What do you see?
I think even personally and with my profession of being the manager, you see a sense more of independence, that they know that they have these sources that they can rely on. So one thing I notice about the older population is just like a lot of things are taken away from them because people think they can't manage and things of that nature. And sometimes that can be true depending on what they're going through. But a lot of times they are able to, but they just need the resources. So what I see is just a lot of like, well, I could still get out and I'm able to do this because I have that, or I know I could depend on, this person, she's coming to help me and she's great, and they gravitate more and they become family. And also on the other side too, seeing people that assist, are especially our older population, but even there's young people too that need those services as well. They have that tendency of wanting to be more, advocating for them, even when they're not there with them. I hear conversations like, yeah, because such and such thought this, and so I had to stand up for her. So I love it. I feel like it's a circle. It goes, hand in hand. So those supports are needed for both. And if you're
Love
actually, I don't mean to cut
this.
you off, but if you actually
Love this. Keep going. Keep going.
if you actually a person, and I feel like we all on this line are, we're very passionate about the work that we're doing. So you're going to feel like that. You know, you're going to want to make sure that you're able to provide the best for your resident, your client, or whoever that may be, because you actually care. And I think sometimes we miss that, because first it can be burnout, you can just be overwhelmed, and those things do get overlooked. So we must take care of ourselves in order to take care of others. So I think that's important.
Yes, 100%. Thank you for saying that.
Mhm.
So I have some thoughts. I'm reflecting on what you've said, and I'm thinking, you know, there's a lot of reasons that I appreciate people in your field. And I'm going to say, I'm going to Italianize your name. And is it Tirana? Am I saying it right?
It's Tarina. So if you think of Serena, the tennis player, just put a T in front of it.
Marina, okay.
Tarina. Okay.
Serena.
I Italianize everyone's name.
I'm kind
I
of
also
with my
I
say
do
it in
that
like my
too.
Spanish version.
Yeah, yeah. You're
Right.
getting like multiple perspectives here of spelling. So
Great.
Tarina,
I'm glad though. This is great.
correct? How am I doing?
Doing good.
Okay, good.
Yeah.
So I like conversations with behavioral health professionals, with people who like community health workers. I also like communication with social workers. And when that happens is something called the interdisciplinary meeting. In a hospital or in the primary care setting, and I'll start with the hospital, we literally sit around the table. And my person talked about their thing, and your person talks about their thing, and we come to a care plan together. Those are the best care plans, and I'll tell you why. You don't always have these people in the same room. Make a phone call if you need to. If you're a medical provider, make that phone call to a social worker who is associated with the patient. If it's in the record, it will often be written in the last post-hospital note. Have those conversations. It will give you it will supercharge your ability to diagnose appropriately. And what I'll say to behavioral health professionals, community health workers, and behavioral, general behavioral science patient care advocates or deliverers, document things. Your records are part of the tapestry. They're their own category. We read them, we use them, they're very important, and you'd be surprised how often some diagnosis that was driving me up the wall. I saw a note from a social worker that made me feel both very stupid and very relieved at the same time. Right away, guys, we're there reading it. We're your audience. Bring it forward. So another thing I wanted to reflect on is wow, what a privilege it is to take care of patients in any capacity. And when you see someone come back with a big smile on their face because they have a fuller life, that just feels good on a human level. And this is going to pay you back dividends every time you do it. Our primary care patients are long-term relationships. You know, I remember when I left my training and left some of my patients, like I still text a couple of them, you know, like it becomes a relationship. We learn to care so much that it becomes part of how we feel. And when you're seeing that success come through the door, it is an incredibly uplifting feeling, because you know what you're doing really does make a difference. Think of that isolation and loneliness. Think of those nutrition issues, and think of other social needs as opportunities to link patients to not just the thing that fixed the box, but also just a more enjoyable lifestyle in their communities. Next slide, please. Okay, so Mrs. Till, and we're going to get medical here. Mrs. Tiller's lab results indicate that she has slightly elevated potassium, low sodium, and elevated kidney markers compared to her last visit. That is important, and I put that in there very specifically for a reason. Let's say they're a little bit out of reference range. They don't make you want to admit her. These are primary care values. I'll say that. But slightly elevated potassium, low sodium, and elevated kidney markers, that is the toast and tea person. That is someone who is eating carbohydrates and drinking coffee. That is the classic story behind it. And when you see slightly elevated potassium, low sodium, and elevated kidney markers in a patient that has those social issues, you're going to start thinking very seriously about this patient's nutritional intake. When examined by her provider, Mrs. Tiller is noted to appear weak, uses a cane when walking, and her skin has a sunken ashen appearance. That is an anemia look, folks. That's what anemia looks like. And you need to know the patient's skin tone baseline, which in primary care you'll tell when the patient walks in the door. But regardless of the skin tone, the ashen appearance will show up in everyone. You will be able to notice as you become more familiar clinically with how patients present. And it's a graying, it's a lightening. If you hold the patient's eyes like this and you see the veins, that is very well correlated with a healthy serum iron. I'm sorry to do this, but this is the only way to teach. If you look there and it is white, that is very highly correlated with iron deficiency anemia. When I was doing medical work in Haiti, when I do that, and I don't get serum iron, that's what I use to diagnose people there. So you can see this in a patient. So she's using a cane and she's walking. Okay. She walks the hallway. She watches her steps carefully, and she walks and uses her cane with her right hand. Her hand is shaking slightly as she places it under her weight. Her breathing and heart rate are normal. Okay. Fide, if you see this patient walk, what's coming to mind for you?
I immediately for me, I would just think that she needs help immediately. She needs to be seen as soon as possible. That is the first thing.
Where do you want her to get seen?
At the closest clinic or maybe at a hospital.
How about her house?
House too. Yeah.
If you think about this patient and think, I'm going to ask you, Fide, pretend you're a community health worker right now. Why do you want to see, with that hat on, why do you want to see this patient's house? Because you're nosy? Why? That's terribly nosy, Fide. Why do you want to see this patient's house?
Because you definitely want to see what her environment is like too.
Okay.
And that will let us know what are some of the limitations that she's dealing with on her day-to-day.
100%. Yes, I am very curious about this patient's home. I saw we got a comment, Fide. Does it give us an answer? Could you ask our colleague to join us?
Oh, yes. We also did receive some feedback in the chat from Elizabeth saying at risk at fall, week walking with cane. That is
Whoa. Elizabeth, why do you come to those conclusions? Please break your thought process down for us.
I think she can't unmute her line.
Okay, well, I will break it down for you. So when you said risk for fall, and I'll ask you to start, Fide, risk for fall, do you think Elizabeth's right?
Yes.
Why?
Absolutely.
Why do you think she's right?
Well,
And I'll
based on
say within the context of this patient and what you know about them.
everything, just now that just looking at her medical description, what we were talking about earlier about osteoporosis and all that stuff. And then now just physically seeing her, how she's shaking, even while she walks, she seems pale, all of that. So
100%. This is I'll rebrand it as what a preventative medicine gold mine we have found today. There are so many things we can do to make this patient safer. I would encourage you to view it like that. Because let me tell you, doing one thing, and I'll give you an example, shaking right hand cane, whoa, we need to do another walk test and we need to write this patient a prescription for a walker now, right now. They need to go home with it. In fact, I'm not letting her home until she has a walker. And if you're the medical license on the line, you shouldn't either, because there are consequences to sending patients home like that. They will fall. Some of them will fall before they get that walker. And if that happens to you, you will remember that for the rest of your life. These patients need to go home with a walker or an assisted device that meets their needs. And if I'm seeing her hand shaking, that means she's not able to put the appropriate force into that cane to compensate what she can't do with her lower body. I want to see her with a walker, and I want to see if she is comfortable with it. And depending on what I have on whatever I have on my facility, I'm going to get her walking with something that's safe. And also, osteoporosis, nutritional deficiencies, hypertension, type 2 diabetes, risk of fall. This patient will fall if you do not prevent. These things are just statistically inevitable at a certain point if you do not intervene. Every day you take those preventative risks away, you give a gift to the patient. It's the gift of safety. Next slide, please. Okay. And I'll say, is there a next slide? Because I know we're at the end.
Yeah, we have about the assessment of Ms. Tiller's condition.
Oh yeah, jump to that so we can finish up. We'll have to skip that question, unfortunately. Thank you. Okay, so let's go into the social needs and digest them. Mrs. Tiller is questioned regarding her social needs screen and living situation. She discloses the following details. 1. Mrs. Tiller lives alone in a one-bedroom apartment. 2. Her adult daughter and son both live within 20 miles of her home. 2 other children live in different areas of the country. She does not have a healthcare proxy or advance directive of any type. She is active at her local church and public housing resident supports group. And her daughter and neighbors often help her with her medications. So here's what we're going to do, folks. We are at the hour, but I hope you like Mrs. Tiller because she's going to be sticking around. We are going to follow this patient through this learning collaborative, through her preventative medicine journey. Next session, we are going to start at these social risk factors, and we're going to talk about what happens when the rubber hits the road. How do we give this person programmatic support? What programmatic support are we thinking? And how can we line up the programmatic support that meets her diagnostic needs, meets her safety needs, and allows her to live the fullest and happiest life possible? Thank you for your service to your communities and for joining us today. So pleased to have met those of you who I did. And I'll say, tell your friends every week for the next 4 weeks. We'll be learning about this content. So Fide, thank you. I will mute myself now.
Thank you. And thank you to all the participants that engage with us today. Again, please, this is just a kind reminder to all to please complete our post-evaluation survey, which is going to pop up on your screen right after today's session. You may access our latest slides and also the recording to this session on our website at nchph.org. And we're also going to be sharing all of the materials via email. Also, the next session is going to take place next Tuesday at 1 p.m. And just remember to use this. You can also use the same link to join. And this is our contact information in case you have any